I am no Zoom expert, but this is Cristy Gupton. I am your Free Market Medical Association of the Carolinas chapter leader. And we want to welcome you to this webinar today and give you a couple of employer case studies, employers that have summoned the courage to try something new and different and explore all the power of direct care and what it brings to the employer space. So starting with just a couple of housekeeping items, I'm going to monitor the chat. And so thank you to Carl Schuessler and Peter Grimes and Bob Nelson for telling me that we're on. And welcome, Representative Wayne Sasser. We're very excited that you're here, and as well as the rest of you. So we are recording. I will send the Zoom MP4 format to you via email, most likely. And if you have questions for any of the panelists, just type it in the chat and I'll keep an eye on that throughout our time here today. So thanks again for joining us. And I want to introduce to you a great friend and colleague and the doctor who had the first entry into creating the Free Market Medical Association's Carolinas chapter. So it was me and Dr. Purcell and David Contorno who teamed up in 2018 and created this chapter. And so thanks for stepping up and doing that, Dr. Purcell. But you have decided to spend more of your time with the DPC Alliance, which they definitely are glad to have you participating with them. And I've taken over the reins. Hope I don't disappoint too much. But welcome, Dr. Purcell, who is going to give us some first-year claims data from a case that he's worked on now for a little over, well, almost 2 years, Dr. Purcell?
Yeah, the claims data is just from 2019, but we've been with them, well, the end of this year will be 2 years.
So if you follow direct primary care at all, you've definitely heard about this case, but what you haven't heard is how the claims data played out in the first year of the plan's existence. So this is going to be very interesting, and thank you, Dr. Purcell. You take it from here.
Okay, thanks, Cristy. So we're going to talk a little bit about our experience with direct primary care in Anderson, South Carolina, which is the northwest corner of South Carolina near Greenville and Clemson University. So we have a 4-physician practice in Anderson, all doing DPC, all outside of insurance plans. So it's all direct care. And so we're going to talk a little bit about how we set that up, and then some of the information on that we've been able to collect on some claims data. I did have one disclosure, and Cristy asked me to put a picture of my book in there. I didn't have it in there originally, but I do have this book is my only disclosure. If you're interested, I'll talk to folks offline about that. But it's just our experience of working with employers in direct care model. So hopefully we're going to talk a little bit about onboarding, engagement, retention. You know, how do you get your employees in there, and then how do we engage those employees and how to retain them, and get a little bit of information, data on how to do that to provide employers. We'll talk a little certainly about some of the challenging difficulties of getting employers in there and work with employers and their expectations, and some ways that we can drive down cost, and hopefully some of the claims information will show some of that. So hopefully everybody sort of a general idea what direct primary care is, but it's removing the middleman from primary care physicians. So we mostly deal with directly with either employer or the patient himself, and collect payment on a monthly basis outside of the insurance companies. And the whole aim and existence of direct primary care is to achieve better outcomes, lower cost, improve patient satisfaction, but also improve physician and clinician experience and satisfaction. So we want happy doctors, we want happy patients, we want lower cost and better outcomes. So those are the things we're trying to look for to improve in direct primary care and primary care in general. And we just think that direct primary care is probably the best way to achieve those targets. So onboarding employees. So this is a very frequent question that we get from DPC clinics across the country is, okay, so you signed up 200 employees, and how do you get all the people into your clinic, physically get them in for new visits? How do they get signed up? How do they get registered? If you're an advisor here or a broker here, you've probably been through open enrollment and that kind of stuff. And how do you get people signed up? How do they choose their plans? Well, this is sort of an extra layer. If you do DPC, they got to get registered in the clinic. And most DPC clinics have a computer system, EMR system that's specific for DPC, and they have their way of registering those patients. How do they get them in? So we work closely with employers and our benefits folks to really try to make it easy as possible for those employees. They have to pick their plan, but they also have to, if they choose DPC, they have to sign up through our EMR system. And so that's why I have communication is the biggest key here. We have to be on the same page with the benefits advisor and the employer, the HR department. One way that we've used is some easy postcards that we made up, and we have thousands of them. So when we sign an employer up, we'll leave them little stacks of postcards, and it has a step-by-step, line-by-line, go to this website, put this login in, put your information in there. It tells them exactly how to sign up. And so it makes it easy. And if you're using, sometimes at open enrollment, they'll use sign up specialist or whatever they want to call them just to help people get enrolled. We actually go and try to train those folks too, so they know how to get their employees into our system. And we push and push and push to try to get employees to sign up before the start date, which is January 1st or whatever, whenever we can get them. Because we want everybody in our computer system, if we can, it's going to use our DPC program on the start date if we can get it. Now, obviously, there's going to be people who lag behind, they don't register, they don't get in, and we continue to deal with those folks. So as soon as open enrollment's closed, we usually get an Excel file. You get some kind of file from the benefits advisor, so we'll get information. Here's the 20 people that signed up for your clinic, or here's the 200, or in our case, 800 people who signed up for the clinic. And so we have a list, and so we know who they are. Hopefully we'll have their email address. Hopefully we'll have their phone number. And so we assign those patients to a physician, and that needs to be worked out ahead of time. If you're a 4-physician practice, who's taking patients, how many are you going to get? You're going to have an internal plan on how to divide those patients up. If it's one physician, obviously you're going to take all the patients. Or if you're in a 4-physician group and only one physician's taking people, you're going to pretty much divvy up all those patients to that one physician. So need to figure that out, how they're going to assign them, and then have someone in your office assign those patients as soon as possible. And along with that, assigning the patients to a physician, you would go ahead and set up their first initial visit as soon as possible. Now, if you have 20 new, let's say you sign up with Sedera and you got 20 employees, you'll probably be able to get those new 20 employees in over the next few weeks, do 2 or 3 new patient visits a day. If you have 800, like when we signed up the county, it's going to take 3 or 4 months to get those 800 people to come through and get in, even using 4 physicians. So begin to start signing up those patients, get them in there. And then what we did is if if Miss Smith doesn't have her initial visit until April, we would see her anytime she needs to be seen for refills, sick visits, injuries, anything that she needed. We would see her for a quick visit and refill and do what we need to do to get her medication. And we would still keep that regular 1 hour long initial visit where we can really get to know the person. As I mentioned earlier, there's always going to be what we call laggers. There's people going to be lag behind and not sign up. In fact, at the end of 2019, the first year we were doing DPC for the county, we still had almost 30 people who were signed up in our clinic that had never went on our website and registered. And that's despite multiple emails, multiple text messages, multiple phone calls, multiple reaches out to the human resource department at the county to say, hey, this person has never registered. We haven't seen them. We haven't heard from them. So we created skeleton charts for all those people. So they have a chart in our system so we can continue to email them. We can continue to text them and say, hey, we need you to sign up before you get really sick and you call us in the middle of the night. We need to know who you are. So I say that just to say there's always going to be somebody who's not going to sign up, that's not going to do it. Interesting enough, we found that for the county, most of these folks are younger folks who are usually 19 to 20, and maybe they're college age, and they're dependents. They're not really the employees themselves. They're dependents of employees. And it's been kind of a sticky situation about how to get those dependents to sign up with us, because some of them are not even living in the area. So again, communication is the key. We continue to work with our county about how to limit those people who aren't signed up, and should we take them out of our system, because we don't want them to be paying if they're not using the service. So we're continually trying to update how we do that. And sometimes we've had a few that they basically said they weren't going to come, so we've just dismissed them from our practice, even though they're still under the DPC program. And it gets kind of tricky there, but the county will put them back into the opposite plan. There's a standard plan they have. So just think about those people who don't come in and a plan to how to handle that, because that can get kind of sticky down the road. Usually what happens is you hear from them on a Saturday morning and you have no idea who they are. You're like, oh, this person's never been seen. So that's something to think about. So here's getting into some of the data from what we started collect from 2019. That was the end of the first plan year. We added in almost 800 patients, 792 in 2019. We had over 3,500 appointments, and that could be a nurse visit, a doctor visit, shots, anything where they were on the schedule to come in and get checked for something. And we dispensed over 3,300 medications, and through our system, it gives you an estimate of what you save just on medication compared to the retail average. So you can see about 53,000 saved. Over 23,000 text messages, about 20% or so after hours, which for DPC wannabes out there, most of those are between 5 and 7 o'clock after hours. And usually it's, hey, I forgot to tell you I need a refill on this, or hey, I need to come in for my recheck visit. So they're pretty straightforward text messages. Emails over 3,000, and some phone calls as well. All those go through our system. Those are any calls that come through our system, or any emails that come through our system. So we're able to track that engagement. So pretty good numbers. I think that works out to about 4 or 5. It was close, about 4.5 visits or appointments per patient, roughly. So one of the things we wanted to track was retaining. How did we retain employees? Did we have 800 sign up and then half of the people left and went back to the other standard program because we were just crazy? We didn't help them. We didn't do anything. So between 2019 and 2020, we had 8 employees leave and go back to the standard plan. 5 of those was a mutual agreement because the services, they didn't feel like the services we could provide were good enough for them. So we kind of said, you know, you probably would be better served in the standard plan. But we added 118 new employees in 2020. So our retention rate was in the super positive, obviously. So we had to find space for 118 more patients who switched from the standard plan to the DPC plan as their colleagues and friends said, hey man, it really does work well. We had a lot of those are pediatric patients as well because we have a DPC pediatrician, which is super unique. He's not part of our practice. He has his own practice, and this worked out well because all the county employees really love to have the DPC pediatrician option. So we were really excited about the retention that the C employees voting with their feet, and they're continuing to use us, and more are coming. And we're expecting to get, the word on the street is that we're going to get some more switching from the DPC plan from standard in open enrollment, which is next month, I think. So patient satisfaction in February of this year, we did a net promoter score. We sent out over 1,700 emails. This went to all of our patients, not just county patients, but all of our patients. And we got about a 10% response, which is about average for when you send out a mass email about how many people respond. And we were able to calculate a net promoter score of 81, which is really, 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 really good, and that we were happy about. If you're not familiar with net promoter score, it's sort of the gold customer service experience gold standard. In healthcare, the average is around 27, depending on where you go search that out. Blue Cross Blue Shield gets about a 7, which is not very good, but all the companies that we really like a lot, Amazon, Netflix, Starbucks, Apple, depending on where you go and search those net promoter scores or what year you're looking at, usually they're going to be in the 60s to 70s. You know, someone who's really, really driving customer service are going to be pretty high. But a lot of the insurance companies that we deal with and cable companies are horrible. You know, they have like -2. So we felt pretty good that we were providing pretty good service for our customers, and they were satisfied that we were offering good satisfaction. So a little bit about the county, the plan overview. So they have 1,911 members. 1,000 of those are in the DPC plan. This is in 2019. We did not get all of those. Obviously, we have a DPC pediatrician, as I mentioned, that got some pediatric patients. And we also have a DPC physician in the community next to us in one county over in Easley, South Carolina. And she got 50 or 60 of those DPC patients from people who were living sort of on the other end of the county. So it was spread across really 5 DPC physicians and a DPC pediatrician were those 1,000 employees and spouses and kids. So the average age, which sometimes can be a signal of how sick people might be, or to try to get a risk assessment. Our average age was about the same between the 2 plans, less than a 3-year difference. Medical claims, you can see the total and how many claims. It was almost equal claims on DPC and standard plan, even though there was a lot more people in the DPC plan. And then you had an astonishing number, and Kyle, I don't know if Kyle's on this morning. Kyle Paul's from Kpi Ninja, collected our data and crunched all these numbers for us. And I think I called Kyle 5-6 times and said, Kyle, are you sure about this? Because this just does not make sense to me. But if he's on this morning, maybe he can clarify that if I tell this wrong. But members without medical claims, 41% of members had no medical claims in the DPC, which is not that shocking. And Kyle said that's not really off the mark because you're going to see so many patients without a claim in DPC. He said, but 44% in the standard plan, which did not have a claim in 2019. And I asked him multiple times, are you sure? I said, that's an awful lot of people who had no claim. And on the standard plan, it's just like a regular insurance. If you don't use it, you have to use it to get a claim. So I said, you telling me 365 people didn't get a flu shot? They didn't see a doctor. They didn't do anything in 2019? And he said, that's what the claims data shows. And he got all the data from EBMS, which is the third-party administrator. He got all the data from the PBM, Southern Scripts. So I was just blown away that many people on the standard plan did not have a claim. You can see the medical spend at the bottom, which is essentially the same when you compare out the per 1,000. But DPC didn't spend about as much as the standard plan, but we had a lot more patients. So hopefully those numbers make sense to you there. So here's what the utilization kind of looked like for us in 2019. So when you add up the E&M codes, which are visit codes, basically all the visits that we had in our clinic, and you had if they went to see a specialist or any other urgent care visits, so any E&M code where they had a visit, the DPC people had a lot more visits, about almost twice as many visits, either seeing us or seeing a specialist for usually screening and other things. So they were definitely using their plan a lot more. The urgent care use was about half in the DPC plan, which was really good for us. The emergency department use was down about 24%. Outpatient hospital use down about 21%. And inpatient hospital was down a little bit. Those numbers were so close together, and the numbers overall for hospitalizations were really small. So trying to get a difference was kind of difficult on that. So, but those are kind of numbers on the utilization. And we liked the less urgent care, less ER, more visits. People were using our services. So we were happy with that. Plan cost comparison. Again, all this was numbers were crunched straight from Kpi Ninja, getting all the data from the TPA and the Southern Scripts PBM. So you can see the DPC costs are in there on the DPC plan, and then the biggest savings were on the RX spend, because a lot of patients were getting medicine through our clinic, or we helped them find generic medicines. We helped them find ways to get access to medicines way cheaper. And of course, we don't use a lot of the very expensive medications that maybe a physician who is, in a hurry, like here, just take this $500 insulin shot and let's just go on down the road. So we were able to save pretty good bit on the RX spend. And the out-of-pocket costs for employees costs were way less because we were doing a lot of stuff in our office. So they weren't getting nickel and dime with labs and fees and extra things. And so the spend, out-of-pocket spend and copays and all were a lot less, and deductibles were a lot less out of their pocket. So when you break that down, it comes down to about a $55, $56 save per member per month when you crunch all the numbers out, which we felt was a pretty good savings for the county. If you do the math on that, it comes out to about it, and even what they spent, they got back in savings pretty much. So we felt like those were pretty good numbers for us. Obviously, there's some limitations to that. That there's no way to risk stratify. I mean, it's astronomically difficult to risk stratify standard plan employees and DPC plan employees. You can look at ages. There's one thing we talked about with Kpi Ninja is they would have to have all the CPT codes, all the ICD codes. They would have to compare those across the two different plans, and it would take hundreds of hours and tons of resources and money to really risk stratify them, to get an idea of, if the standard plan patients were super sick, compared to our patients, would be a difficult task. So we don't have a risk stratification here. However, we do know that we looked at the top, Kpi Ninja was able to give us the top 20 highest claims. We looked at the top 20 highest claims, and 11 of those top 20 were DPC patients. And they were super duper sick people, ICU visits, bypass, all kind of stuff. So when you look at just that 1 year snapshot claims data, our patients, and comparing the standard plan and the DPC plan, the illness severity was pretty close together, because a lot of our DPC patients had higher claims overall on those when we looked at the top 20 claims. So that is a big limitation, trying to risk stratify those to see who's if you're going to compare them, is one group really sicker than the other? And it's kind of difficult to do those numbers. Again, we're approaching the end of this year, and hopefully we're going to be able to run these numbers again, have more information to try to share with the DPC community, but also with other benefits folks. And then we did share all this information with Anderson County as well, and they were definitely happy to see the information, and we're continuing to work to make the plan better any way we can. Things that we've done this year that are different are we added at our own cost a registered nutritionist who works for us full time now, and so we've started referring tons of people to nutritionists, and she doesn't even live in our community. She lives in Tennessee. She does everything online, virtual. So that's the beauty of what we do in DPC. She can still get in, have access to all the medical records, and then do virtual visits and emails and text. And we have a healthy eating series, which is a 6-part video series that all the patients can go through and then follow up with a nutritionist. And then she has a 10-week, very detailed diet program that she does with people who are willing, who want to do it. So we have a program right now we're doing with some very brittle diabetics who are on very expensive medication, and we've picked out like 10 that we take care of, and we're having her work really close with them, working on diet and nutrition. And while we have purchased Freestyle Libra sensors for them, so they can see where their glucose is going up and down every minute. And then we're doing these pilot programs to try to help get some of these folks off of these expensive medications, using nutrition and diet. And our next step will be adding full-time behavioral health. We have several folks that we work with already. But even still, even with the county, as far as the county is concerned, they have insurance, and our counselors that we use take the county insurance, but they're still overwhelmed. and there is still a copay and deduct. There's some that they have to pay out of pocket, which still limits people. So we would like to have our own behavioral health specialist counselor that costs the patients nothing. And of course, we would use them not just for county, but we would use them for all our patients. And so that we have over 2,000 patients now, and we feel we can keep a behavioral health specialist counselor pretty busy. So that would be the next thing, and all those things are all value added, meaning that we will not change the price or anything. It won't cost them extra to get those services. So hopefully that information, we'll get more information by the end of this year and continue to share that with the community. But we were pretty pumped about what we've got so far, and just thanks to Kpi Ninja for the help that they've provided for us. They've been really good, supportive, and working with the county and the benefits company, and allowing access and all. So hopefully that'll be some good information, and I'm sure you guys have questions. And if you see, what do you see there, Cristy, on?
Yeah, Dr. Rick Botello, who's a great primary care doctor in Charlotte, he says, great work, thumbs up. Lowering costs is DPC's low-hanging fruit to improve value-based care. What are employers' evolving expectations about measuring quality outcomes? How can DPC demonstrate superior clinical outcomes as compared to the standard? What outcomes can DPC measure that go above and beyond the status quo?
Yeah. Well, how much time do you guys have?
You're right.
So, I mean, obviously we're all tweaking what we can do in DPC. I will say this, everybody wants to know, they want proof. They want proof that DPC is better or works or something. But for a lot of us, it feels like they're holding DPC to a different standard. So every day in our community, people go to see a traditional family physician in their office, and there's no proof that what they're doing is saving people money or doing anything, and it seems to be okay. And we're definitely trying to lower costs and improve outcomes. And we want to work to try to set up the data, get the information to try to show that. I know there's the DPC Alliance is really working with some larger groups to start collecting that kind of data. Because we have close to 300 Alliance members across the country, and if we could use that as a resource to really pull out information. The question is always is what data are you talking about, and what are the numbers that they're looking for, right? So if you're going to say the only way you can prove that you're better is show me that your A1Cs are better, show me that your blood pressures are better, show me that people are not overweight in your clinic, show me people that are not hypertensive in your clinic. If that's what you're saying, you prove to us that DPC is better by showing all those things are better. That could be very difficult, because it's even difficult to do that in traditional medicine. So we're working with several large organizations to try to put into play collecting some of that data. In DPC, some of the difficult part of that is most of us don't use Epic and all these massive computer systems that are just data cogwheels. And DPC is what it is because we don't spend 30 minutes typing on a computer and putting coding and billing in there. We're spending more time with patients. But if we're forced to go back and say, hey, we got to put data, we need more data in your computer so we can prove that what you do is right, I think we lose patient contact, we lose patient hours. So we have to walk that fine line and to see, you know, where can we get the information? Where can we get data that's helpful? You know, I use all the information in my, you know, A1Cs, hypertension, you know, weight gain, all those things. I use those in my clinic, but it's a one-on-one between me and my patient. But to take all 600 of my patients, or let's say I have 100 diabetics, and my average A1C is 9 because I can't get 20 of them to stop drinking soda, you know, that's not very useful overall. So, but yes, there are organizations that the DPC Alliance and DPC physicians across the country are working with to really figure out, okay, what's the data that helps, that can show improvement, and that we can share with employers. Because I'm not 100% sure. I know the large employer we work with, I'm not 100% sure they would know what data they wanted. Like, they don't come to us and say, hey, we want to see your A1Cs. You know, the employer doesn't come to us and ask us that. In fact, when we signed up the county, you know, David Contorno and the local insurance folks and the HR and the CFO, all these people never asked, they never said, hey, we want y'all to provide us A1C data. We want data. What data can y'all give us at the end of the year? All the stuff that I presented today was all the stuff we did on our own to give to them. We paid for, we collected ourselves to try to show them, you know, hey, we're trying to do what we can do to be sure the patients are getting seen. They have access. They can get the help they need easy. And we're trying to lower the cost, and we're trying to keep them from going to the hospital, keep them from going to the ER, keep them from going to urgent care. So it's always a difficult thing. And I think there'll be more to come. I mean, DPC is so new that we're just trying to get our feet up under us really good so we can begin to work together to collect the right information to continue to show employers on a primary care level that this is really good access.
Hey, Dr. Purcell, I think Kyle Poss from Kpi Ninja wants to add a little flavor here. Kyle, can you speak? Are you?
Yeah, I can speak. I was just trying to answer some of these questions and wasn't sure how it worked. So I'm not sure if I was flagging you or anything like that, but okay. I don't have any input at this time. I was just trying to get through some of these question and answers on the screen.
Well, add a little comment of your own if you like.
Sure. I don't know how much more I could add to the analysis or speech that Dr. Purcell said, but some of the questions that we've been seeing in the chat boxes. So let me get back to some of these. Dr. Botello asked what kind of evolving expectations are on the employer side. We at Kpi Ninja, we work nationally on this stuff, and we see a mix. It's pretty well mixed. So there's still a large group of employers who aren't really asking for any data. But then we're also seeing larger and larger groups having data as a prerequisite to even consider working with direct primary care. The metrics are looking for mostly based off of just cost of care. I think ROI is the most important value to them. But then if we can also show value via utilization, increased utilization, or lower costs on medications, just helping provide better access to employers. That net promoter score is a big one as well. So those are some of the metrics that we're seeing. So, I mean, I think it's a growing amount of employers who are starting to say we need to see the value of our investment in this, especially with COVID. We saw a big pickup in employers asking for ROI analysis just because, they didn't know what, how the economy was going to work out for COVID. And then as far as, I think, let's see if there's any others I can answer here. Yeah, I think most of these are more for Shane than they are for me. Andrew Roberts did ask, is the takeaway better benefit and break-even cost? All the indicators we're seeing show that. There's still some data limitations. Dr. Purcell did discuss, like, risk scores. I think we were able to mitigate most of those limitations in some of our follow-up analysis. So all the indicators show that DPC is providing, much better benefit, much better value, and cost savings at the same time. But it's not like a 100% certainty. There's still a little bit of unknowns in there. So I think that's all I've got to add.
Dr. Purcell, Peter Grimes asks about scaling DPC nationally. Is that a conversation you're having at the DPC Alliance?
Not so much. As far as, I mean, yes, we'd love to see DPC take over the whole country for primary care. And I'm glad Peter's here because he's trying to help move the needle for sure. So I would say that it depends on what you mean by the word scale. I mean, obviously direct primary care and primary care is not Starbucks. So you cannot open up a Starbucks. You can't open up a clinic and put a doctor in there and call it DPC. And that's part of the problem. It's almost like trying to scale moms. I heard somebody say, how do you scale mothers? Well, you can take somebody and they can have a baby. That don't mean they're going to be a good mom. So we have to really search out and find physicians who understand the model and that will really work to do DPC and be DPC. So the rate limiting step, I've said it for years, and direct primary care is the physicians, because there's national companies that'll sign up huge employers, and they'll take a doctor and put them in there and call it direct primary care, and they may, they may show some benefits, but it's just different than what we're doing, because we're really on call 24/7 for our patients to try to help them any way we can. We need more physicians, and I think Peter would probably agree with this, and hopefully others here would. We need to go to the medical school level. We need to go to school level and start working with the students, and even first and second year students, get them to come to our clinics, get them to understand how direct care works, and working with the students at student level, get them to come back as third year, fourth year students, get them to come as residents, seek out residents that are interested in doing old-fashioned family medicine. So we really got to start earlier so they can see the value in what we do. But if you don't have, I mean, honestly, if you don't have the entrepreneurial spirit to do DPC, most people are just, obviously we hire employees. If you're an independent physician, we've been looking for a physician for over a year now. So we would love to hire another physician to come work with us. And so you can still experience the DPC model without having all the headaches of running the business. But most people who understand DPC, we're finding, are the entrepreneurial type physicians. So they're going to want to start their own practice. And there's some difficulty with that. It all comes down to money. Where am I going to get my money to start? How do I make a living to start? How do I pay $300,000 in school loans while I'm trying to start? That's always a big issue. So as soon as Peter hits that $200 million lottery, maybe he can start helping people pay off their debt and try to get down that road. I see some of the questions here, so I'm gonna try to read through some of these real fast. We got a few more minutes left. Andrew Roberts says, when a new population is brought on board, what are the first things you tackle? I assume he means from a medical standpoint, you know, when they come back, when they come on board. Basically, when we do our initial visit, we're just getting all the information we can. You know, what medications are you taking? What health problems do you have? What are your concerns right now? You know, what do you want to work on? What's important to you right now? Just trying to get to know them some, you know, where you work, what kind of job are you doing now? You know, how does that affect your life? You know, who's at home with you, or do you have kids, or your husband there? Luckily, if the whole family's coming here, that gives us a little more perspective on, you know, the relationship between mom and dad and the kids. So we're basically beginning the long process of getting to know the people, which is what family medicine, it's why the family medicine is so beneficial, is if you can build a long-term relationship, you can get to know this person. So when they do call you at 11 o'clock at night, you can say, well, oh, that's just Buddy. I'm not worried about Buddy. He gets a little freaked out every now and then, and I'll just send him a message and he'll be fine. So that's kind of what we're starting to do when we first get people in there. And then we it's just all about building relationships. I mean, that's how everybody on this call, whether you know it or not, that's how you're doing everyday life, is you're trying to build relationships so you can get more customers or get more patients. So we just start building those relationships.
Hey, Dr. Purcell.
Oh.
Dr. Botello is asking another question to Kyle, and I wondered if a part of the answer, Kyle, you wouldn't mind telling everyone what Kpi Ninja is all about in a nutshell, just so for the people on the webinar who aren't DPC physicians, they'll know a little bit more about Kpi Ninja.
Sure, Cristy. Yeah, so Kpi Ninja, we are a healthcare analytics company. So we measure cost of care, quality of care across multiple different healthcare markets. That includes hospital systems, health insurance plans, and then direct primary care clinics as well. And then some of us are also researchers by trade, so we're constantly trying to understand and research the downstream impacts of direct primary care, as well as the impacts on quality of care of this model across the country. So we work with DPC clinics across the country, just trying to provide them with data and how do we interpret that data and what maybe best practices are we seeing across the country. As far as Dr. Patello's question about where DPC outcomes measures might be going, or what other cutting edge DPC practices are doing to reduce costs and improve quality, it's pretty much a hodgepodge. I mean, every clinic is built differently. They practice differently. Different markets and different population groups have a lot of impact on that. So I can't say it's trending in a certain direction. It's kind of going all over the place. We're seeing a lot of fun innovation in different pockets of the country, and I don't know which one will be, which type of innovation will be most successful. It just seems like they're all kind of doing their own thing at the moment and having fun with it. So I don't know if there's a good answer for you there. Some of them are doing they're spending a lot of time on coding and care management, and looking at claims data on a routine basis to identify high-cost drugs that they might be able to intervene on, or making sure any patients who are going to the emergency room more than 3 times in a year are just getting that extra touch on their end.
Yeah, Cristy, let me go back and answer real quick. Well, I just lost it. I can't remember. I think it was Andrew, maybe. There was a question there.
He wanted to know, chronologically, what's the smartest thing to tackle first, and then how do you progress on?
The last thing he mentioned was, where do you see the biggest amount of area for savings, is what he asked at the end.
Okay.
So obviously the areas we see savings and you benefits folks could chime in here too, because we see savings obviously on medications, because we do in-house medications, which can save a ton of money. Plus, if we're working closely with the patients to try to limit expensive medications, like inhalers and things. So we're going to try a generic inhaler before we would try a $400 a month Brio type medication. Obviously labs, because we do a lot of our own labs in-house, and they're dramatically discounted. So lab work can be dramatically saved on pricing. And of course, testing. So because we're going to try to send people to imaging centers where we can get deeply discounted prices on x-rays, MRI, imaging, and then procedures, because we do a lot of procedures in our own clinic, sutures, skin biopsies, EKGs, those kind of things. And those cost nothing extra to do them. So even knee injections, some things that we can do in our clinic. So those will be areas that we see significant savings. And sort of to piggyback on what Kyle was talking about, back in, I guess in a couple months back, the American Academy of Family Practice had the DPC Summit, and one of the talks, the early talks, was about the 10 steps. It was 10 ways to identify a value-based primary care clinic. And it basically talked about 10 different things to look for. And so I don't have it in front of me, but when we went through those steps, and my partner and I, we basically had 8 of the 10 we were already doing in our clinic. Most DPC clinics are already doing those already. It was things like same day, next day appointments, the transparent pricing, what it costs up front for everything, the access through email, texting, video. You had to basically have online access to your physician. The big things that there was some risk stratification. One of them was about basically having your patient's risk stratified. And so we're looking at concepts about how we can do that in our own patient population, trying to say, okay, I have 600 patients, and trying to look at who's the sickest in my group so we can follow them better. So there were some little things that we weren't doing, but most everything, when you go and look at those steps and, what does it mean to be a value-based primary care clinic, we were doing almost all of them already. Offering behavioral health services, dieting, diet education, all kind of stuff that we were doing already. So
Dr. Purcell, and I'll just say one more thing to Andrew Roberts, who, by the way, is a great colleague and friend, benefits advisor up in the great state of Massachusetts, and a fellow holder of a master's degree in health benefits design. I was so excited to have him as a fellow student in that program. But Andrew, if you'll make sure you stick around for the second hour, one of the things that Dr. Ben Aiken and I are going to be talking about is when DPC can step in and coordinate a surgical procedure and keep that sort of under the radar of the PPO networks, and direct that care in the smartest place where it can go with the highest quality. So I think that is another huge opportunity for savings in a health plan where DPC can really shine. And so that'll be part of the next case study, so stick around. Let's take one more question, Dr. Purcell.
okay.
Rick, Dr. Botello wants to know, how do you afford to do all the great things you're doing with all these value-added services without losing money? I wonder that myself, but I know you're doing a great job and you're not losing money. So just give us that answer real quick before we move on.
Well, I mean, obviously the easy answer to that is you keep your overhead down. I mean, so if you're not if like in my old clinic, I used to run urgent care, and we accepted insurance, and I had to pay 2 people all day, every day to deal with billing, coding, try to get my money from the insurance companies. Well, that was in benefits, salaries, all the stuff that goes along with that. That was $100,000 a year I was spending to pay those people to collect that money. So on top of we would spend $500 a month just sending out statements to patients to try to get our money. So you think about the overhead that goes along with the insurance billing and coding, and not having the employees to deal with that. All our employees, if all our employees that work for us are all dealing with patient care, they're not dealing with insurance companies and claims and coding. We don't have anybody in a back office that never sees a patient that's basically trying to collect money somehow. So it all comes back to overhead and just managing your overhead. I would say that DPC, and hopefully there's some other DPC doctors on here. I know Ben's on. I see him. Hopefully Ben would say the same thing, that DPC physicians are fanatical about saving people money, about doing what's right for patients, which often is what's cheapest for patients. And Cristy, you know this, and I'm sure other advisors would speak to this too, that frequently the most expensive place to get a procedure done is usually the worst place to get it done. So cost is inversely proportional to success in healthcare. So we're fanatical about trying to save people money, and we do the same thing in our business. Where can we get the cheapest paper? Where we can get the cheapest copy machine? Often in a traditional practice, if it's run by a hospital system, the front desk person doesn't care if the copier's broke. I mean, they're just going to go get another $10,000 copier or something. I mean, we can't do that. We're looking for ways to cut costs in every way we can. So that's some of the entrepreneurship spirit, and hopefully maybe Ben can talk about that a little bit, because now that he's taken over his own deal, he's probably jumped in probably deeper than he wanted to. But so it's about keeping the overhead down. That's what it's about. And it's just like any other business. If you own a hardware store, if your overhead kills you, then you're not going to make any profit. So we have to make money to pay our bills so we can help patients. That's what we do.
I would echo that in terms of the overhead piece. And I mean, I think we don't have huge margins. I mean, this is not a rapidly scalable kind of, venture-backed play. It's a slow process, and we have to, run lean where we need to. But as we grow, I think similar to Shane, like we already have some behavioral health, a behavioral health component embedded in. There's no added cost for members. Our goal is to have physical therapy embedded in. And if you look at the projections, we're able to do that and not charge anything more to the patients at the end of the day. So we do need to kind of grow the membership and add additional doctors before we can do that. But the model supports it, which is really exciting from my perspective in terms of the value that we're able to bring at the cost we're able to charge.
Well, thanks, guys. Dr. Purcell and Kyle Poss, we really appreciate the work you did and what you're continuing to do. It's 9 o'clock, so we're kind of halfway through our meeting here, and I want to invite Bill Thomas from Sedera to unmute and share his video and share his screen. Dr. Purcell, if you'll stop sharing your screen, and then Bill, let me know if you're having any trouble at all sharing your screen. I'll try to do what I can. I'm no Zoom expert. I'm a novice at Zoom.
No, good morning. How are you, Cristy?
Good. I am very good. So everyone, please welcome Bill Thomas with Sedera. Sedera is a medical cost sharing community that fits with direct care like a glove, like a marriage made in heaven. So I wanted Bill to just take about 10 minutes between case study number 1 and case study number 2, so that especially all the direct primary care doctors out there and benefits advisors out there and employers and, well, everybody on the call to give you just a nice foundation for what Sedera is and the kind of alternative healthcare tool that it presents. And I can absolutely see a more substantial webinar that we can do separately to really dig deep into the Sedera model for whoever's interested. So you can let me know about that later, and we'll set up another webinar. But for about 10 minutes, Bill's going to give us a glimpse into Sedera. Thanks, Bill.
Thank you, Cristy. Thanks for the introduction and thanks for having me. It's good to see some familiar names on here. I can't see everyone's faces because I have my slide deck up, but happy to be here this morning from sunny Austin, Texas. So again, my name is Bill Thomas, head of sales here at Sedera. We've been a medical cost sharing organization since 2015. And the significant difference is we do not have a religious aspect when you join Sedera. So we have a group product and an individual product. And as Cristy mentioned, we pair very well with DPCs. We're a huge advocate of the direct primary care movement. I myself am part of Dr. Katrina Iqbal here in Austin. So my family and my 5 daughters were all participants of a DPC membership. So medical cost sharing, it's not a new concept. It's been around since the 70s. The Christians did a very good job of taking care of one another. Our founder started Sedera back in 2015, and we have over 30,000 members currently within our community. And so when someone doesn't understand medical cost sharing, I bring it down to the most basic terms and try to relate it so you understand. It is not health insurance. First and foremost, it is 100% not health insurance. But what is it? It's an alternative way to pay for your health care. So think of it this way. You have direct primary care, Dr. Aiken, Dr. Purcell. They're taking care of the gas. They're taking care of the oil changes. They're taking care of the brakes. They're taking care of your transmission fluid. But what happens when your 18-year-old daughter hits a mailbox and totals her car like mine did? That's when Sedera kicks in, okay? So we are there for the larger catastrophic, and we work just like a car insurance deductible would work. And I'll get into that in a moment. So the beauty of Sedera is you have the freedom from networks, right? Insurance companies dictate where you have to go for your care. Sedera, if you're diagnosed with cancer, if you feel like MD Anderson in Houston is your best way to get your cancer taken care of, guess what? You can go to MD Anderson. And everyone within the community is a cash pay member. Okay, so there is no insurance card. There is no $20 copay and go visit a doctor. And another reason why we're big fans of DPC. So when I go to my doctor and it falls out of her scope of work, for example, I have one now. I have to go get an endoscopy. She referred me to a local gastroenterologist, and I got a cash pay friendly price. And I know at that point, I pay up to my IUA, which I'll describe here in a moment, and the rest would be shared with Sedera, okay? People over numbers. So we are if you go and look at our Google reviews, you look at Better Business Bureau reviews, you'll see that we have very happy members. The biggest compliment we get is, oh my gosh, you guys actually pick up the phone. You actually have a human being to talk through and navigate our healthcare. We take great pride in educating our members on how to navigate the system. It's the only industry in America where you walk in and you don't know what the heck you're paying for, right? There's no transparency of pricing. So we coach our members on how to be savvy consumers of their healthcare. And once they get it, when the light bulb goes off, it's amazing. As I mentioned, we do everything on a per sharing need basis. And so when you join Sedera, you pick 5 options, whether it's the individual product or the group product. We have a $500 initial unshareable amount, which we call an IUA, all the way up to $5,000. And I'm going to walk through an example here in a moment on how that works. We ask our members to make a commitment to a healthy lifestyle. As we all know, if you're committing to your diet, you're committing to exercise, that you're less likely to go to the doctor. And so therefore, if we're all doing our part in the community, guess what? Less doctor bills and more money in the community for sharing when a catastrophic event happens. So let's walk through how a large medical bill or when Sedera medical cost sharing would kick in. So we define a need as 1 or more medical expenses caused by a single accident or illness. So if we have that initial unshareable amount that I mentioned earlier, we have the 5 IUAs that I mentioned. And so if I was a member of the community and I was in the middle option, the $1,500 option, and I was out playing basketball, broke my leg, rushed to the hospital, had an MRI done, and they wanted to perform surgery on me. They inserted rods into my legs. They provided me antibiotics and pain medication, and then I'm sent home to do 3 weeks of a rehab. All of those procedures, all of those expenses are considered one need. I would be responsible for the first $1,500. After that, the rest of the bills would be shared with the Sedera community. I would simply take a picture of the itemized bills on my mobile-based app, upload them to my needs processing team, and the bills would be processed. We work with our sister company, the Caris Group, that has done bill negotiation and patient advocacy for members, insurance companies, and other Christian health ministries since the mid-90s, and they also do it for our community. So if we get an outrageous bill for that surgery that I just had, they will go into bill negotiation with that provider on my behalf in the Sedera community's behalf. At the end of the day, our members are never balance billed. Sometimes we're very successful in negotiating bills down, and sometimes we're not. But the reason we do that clearly is to save that bucket of money for the rest of the community. Now, unlike insurance, we do not have a calendar year flip. And so what I mean by that is if I was 6 months removed from my rehab, hurt my leg again and had to go in for surgery, they noticed my rod in my leg shifted and I had to have surgery again. If I did not go 12 months symptom free, my second surgery would be $0 out of pocket. Let's throw that over what it looks like in the insurance world. If I have the same accident on insurance and it went down in August, I go to January 1st, open enrollment, right? I'm on an insurance plan, deductible resets. I have to have that second surgery in February. I would be out of pocket again on my max out of pocket for that particular surgery. So huge savings on the back end, as you can see. And if you see here at the bottom, similar to deductible, but we do not call it that. We limit the out-of-pocket exposure on the big stuff for an individual 3 and on a family 5. And so what that means is if I have 3 large needs that go over my $1,500 IUA in a calendar year, the 4th need is shareable from $1. Here's the mobile-based app I was referring to. Members can submit their bills on their laptop or mobile-based phone. They can track their medical bills on their portal, showing where it is in the needs process. They can contact member services through this. They can contact 2nd.MD through this. Everything they need. This is basically their card. Okay, there is no insurance card. This is their card. So why would Sedera not work for someone? This is it, right here. When you walk into a small employer group, Sedera is not going to work for everyone for a variety of reasons. Maybe 1, it just feels weird. They want their insurance card. Number 2, pre-existing conditions. So we do not turn anyone away. We don't tell anyone, we don't do any underwriting. We don't raise prices for a certain group because they're unhealthy, but we set our guidelines in a manner that it might not make sense for someone to come on. And so pre-existing, which exists in all medical cost sharing organizations, everyone handles it a little bit differently, but the way we look at it is you do a 3-year look back Anything they list on their application, any symptoms, illness, or treatment is considered pre-X, and therefore in year one, nothing is shareable. And then as you can see on the screen, it tiers up over time. So what I would tell someone is, how much risk are you willing to take on when you join a community, knowing that nothing would be shareable in year one? So it's really their choice, but it has to be educated and communicated very clearly that this is transpired, because we do not want to have an unhappy member. We do not want to have someone get into debt because they did not understand the pre-existing clause. So how do we handle the small to medium costs, right? Those oil changes, tire rotations, gas, etc. So as I mentioned before, we're big proponents of the DPC movement. This is a map that we've created, and you'll notice that there's not that many dots on there compared to if you went to the DPC Alliance or if you went to another mapper out there. You guys know better than I think last I heard there's about 1,500 DPCs in the United States. No one can give me an exact accurate number. We probably have about 600 DPCs that are currently registered with us. And so what that means is when we sign on an employer group or an individual, my inside sales team and my regional sales reps and affiliates like Cristy are actually promoting DPCs in that area. And we're asking them to go to our map. And guess what? If they sign their employer group or an individual up for a DPC, we offer a 14.5% discount off their monthly contributions. And the reason we do that is we have data showing that a member of their community that has a DPC attached to it saves the community significant amount of money because they are navigating their healthcare. And so we extend that savings onto our members. We also work with virtual primary care, and we also are starting to log free market surgery centers around the United States. Unfortunately, there aren't very many. We're lucky to have one right here in my backyard in Austin, Texas. There's also, everyone's familiar with Oklahoma Surgery Center. And on many occasions, if a member of ours, it doesn't even matter if they're in North Carolina, South Carolina, if they're willing to fly to one of these free market surgery centers, in most cases, we waive the IUA totally and pay for incidentals to get them there. Outside, so some of the preventive services, the individual penalty and the individual mandate went away in 45 of the 50 states. And so along with that, we decided here at Sedera that of those high cost items that went, if you did not provide a MEC, we decided to lump into our membership preventive colonoscopies over the age of 50, preventive mammograms over the age of 40, childhood immunizations, flu shots for all ages. And just recently we added mental health up to $750 after your IUA into our membership. So all of these are paid at 100%. And are part of the offering. I'm sharing pricing here. This is our group product pricing. Again, in the insurance world, the 500 IUA, that would be what you would call the platinum plan, and then the 5,000 would be considered the bronze. We only have 2 age bands within our group product, the under 30, which is right here, and then the over 30 down here below. This pricing is on our website. Again, we're all about transparency. Everyone pays the same price. And if we ever have to go up, we go up as a community. And if we ever go down, we go down as a community. That's it, Cristy. Did I hit my 10-minute mark?
Almost perfectly. So I just wanted to comment from a personal perspective on a couple of things that you brought up. So I, full disclosure, I am a member of the Sedera community, and I help employers tap into this great resource. If you're an employer on this call, and let's say you have a spousal carve out on your plan, you don't allow spouses, this is a perfect opportunity to get those spouses on your plan a better strategy. If you have unbenefited employees or seasonal part-time, this is still a great way to give them a healthcare option that maybe no one has shared with them before. Bill, you mentioned pre-existing conditions, and I'm with you on that. Sedera is not for everyone, especially if those pre-existing conditions are creating immediate large out-of-pocket expenses. But I'll just tell you, as one of your Sedera members who I think June 20th or something like that was my start date, I have a pre-existing condition. I take medicine for my thyroid, I take a statin, and I have type 2 diabetes. You know, hey, I'm just part of what, the millions, I don't know how many millions of people that are in that same scenario, but I still joined Sedera anyway because I'm frankly just not concerned that between me and my new direct primary care doctor, Dr. Kramer in Forest City at Main Street Family Medicine, I think he and I can manage my lifestyle chronic disease quite well, thank you very much, now that we have constant contact with each other and I don't have to wait 90 days to speak to him again so that he can get reimbursed from an insurance company. So I think we can manage that better. And indeed, we already have. I truly believe Blue Cross and Blue Shield of North Carolina was actually making money off of me and the drugs that I was taking when I was using their PPO network to be a third-party payer. So I honestly don't believe anything ever had to be shared when I was in Blue Cross's pool related to my pre-existing conditions. And that's been going on for 10 years. I don't think in the next 10 years, it's gonna have to be shared either. I'm going to still dedicate to a healthy lifestyle, and my DPC doctor and I are gonna work out the rest. So from a pre-existing condition standpoint, I mean, yes, if you're in active cancer treatment or you're about to have a very expensive surgery, Sedera is really not for you, and maybe plenty of other examples. But lifestyle chronic disease where you can manage that with healthy diet and exercise regimen and maybe a couple of oral medications, I think you and your DPC doctor can handle that just fine. And if Sedera offers you a way to save money, I encourage you to look into it. Please hit me up for my personal perspective on it in a separate phone call or something, but I'll just tell you on this webinar, when I made that change to Sedera, it saved the Gupton family an immediate $700 a month when myself and my two healthy boys vacated my husband's very overly expensive Blue Cross plan. And of course, we reinvested that $700 a month, just a fraction of it, into a direct primary care relationship. And between me and my DPC doctor, we've found, out of the 4 medications I take, we found 3 of them that I can get for free at Publix. So, I mean, I'm just here to tell you my personal story. And I think that anyone who has any curiosities about how Sedera works, please reach out to me. I'll be glad to give you my perspective on that. So we're gonna move on now to case study number 2. So Bill, if you don't mind unsharing your screen, stop sharing yours and I'll share mine. And while we're making this transition, I want to introduce to you Evan Bruder, who's going to jump on with me and help explain the first part of this second case study. Let me get this into slideshow mode. Okay. I hope I have successfully shared my screen. Evan, can you see it?
I can.
Okay. All right. So this is a restaurant group in a beautiful Asheville, North Carolina. They hired me in October. We spent many hours redesigning their plan and tackling a few areas where we felt was easy, low-hanging fruit, and then a couple that were really innovative. And this employer was, very courageous, wanted to do things in a transparent way, and had no interest in being part of the status quo. So I was lucky in that regard. And they had sort of dipped their toes into direct primary care, but the claims data told an interesting story. that they hadn't really fully bought into it. There were claims that I saw for pediatrics and internal medicine and labs and imaging, when they should have already known that the first DPC practice that they adopted could do that for them at no cost, at least a portion of it. So the claims data just told a story that the message of direct primary care hadn't been fully bought into, and so we needed to help rewire their thinking and reframe their perception around direct primary care. And we wanted to expand it too. The employer said, you know, it would be great if we had a female doctor involved. It'd be great if we, you know, just gave a few more choices. And kudos to Dr. Ben Aiken, who was the first direct primary care doctor they forged a relationship with. He was so gracious in saying, yes, and, you know, I don't mind bringing, you know, 2 of my other DPC competitors in Asheville onto this plan. And frankly, his graciousness in welcoming his colleagues turned out in more members to him. So it was all good. You can see there just a snapshot of the benefit summary. I hope it's large enough for you to see, but you can see in the direct primary care plan for employees who choose direct primary care first, they have no deductibles, no coinsurance, no copays, and even for labs and generic drugs, we had you know, advantages. We took down the barriers to that so long as they started with direct primary care. And you can see the 3 DPCs over here that we chose. In the middle here is Dr. Ben Aiken's group, Lantern Health, and then Asheville and Integrative Family Medicine, also Asheville-based direct primary care practices. So this was embedded into the plan, and we really felt like employees got the message this time that if they start with direct primary care, everything else in the downstream part of the healthcare system would come to them at a more affordable price. And you'll see that play out here in just a second. So having a foundation of direct primary care gives you incredible flexibility to do things that an insurance company, one of the BUPAs, Blue Cross, United, Cigna, or Aetna, just won't allow you to do, or they'll just, you know, make it where there's no return on that investment. So it was just important to stay in innovation mode, and having direct primary care as the foundation of your plan gives you that flexibility. So in trying to innovate the RX benefit, the prescription drug benefit, I hooked up with Sona Pharmacy of Asheville and Sona Benefits, which is their pharmacy benefits manager. And we came up with a wholesale pricing plan. And then we just layered on top of that a transparent dispensing fee. And that was Sona's their only stream of revenue, but they had wonderful wholesale pricing. So the fact that they offered that wholesale pricing to our mutual client was a real win for them. And then being able to rid themselves of spread pricing and other, you know, rebate rigging and other kinds of shenanigans that were going on their plan the prior year, where Optum was their pharmacy benefits manager, you know, layering on a transparent dispensing fee that frankly was higher than their prior dispensing fee. But let's face it, when you're rigging the rebates and you're making all your money on spread pricing, you can have a cheap dispensing fee. But when you're honest and transparent, the dispensing fee was higher, and we decided we were going to take that chance anyway. And I think you're going to see how it played out. So Evan, why don't you take it from here for the next 4 slides, and I'll interject as I feel like it.
Sounds good. Thank you, Cristy, for having me on. And it's good to see everybody. Thank you all for joining this morning. you know, as Cristy said, when we first kind of got together to build out the RX component of Katie Button Restaurant's plan, we both kind of agreed that, you know, we really saw that the future of healthcare is local. And, you know, that's originally why Cristy kind of approached us. You know, we have an independent pharmacy here in Asheville, North Carolina. And, you know, she wanted to incorporate that local RX portion with direct primary care with Dr. Aiken and his group and really build a pretty unique plan in the area. There's not really many employer groups doing that in Western North Carolina. And so it was a big leap of faith. So Cristy, thank you for doing that. But really, you know, as we sat down on our first meeting, our goal was to find a way to really integrate a pharmacist into the team for Katie Button Restaurant employees. We both felt like pharmacists had a lot of knowledge that a lot of times employer groups don't get to tap into. And, you know, we had clinical pharmacists that were, you know, willing to engage with employees and kind of meet them where they are and just provide an additional resource on a medication side that a lot of groups just wouldn't get. So, you know, the first strategy that we kind of took to is direct contracting. Like Cristy said, we built, it's a full network, so Katie Button Restaurant employees could go to really any pharmacy in the area. If they went to another pharmacy that wasn't Sona, it was a transparent pass-through cost just with an admin fee. And there was an incentive to use Sona with that wholesale price plus a dispensing fee. But really, you know, where we kind of tried to dive in with employees was actually trying to review the claims data before the plan even started. So we had a full RX report from Optum. Our pharmacist sat down and basically started highlighting opportunities for not only plan savings, but also just scenarios where it seemed like employees might not be taking the correct combination of medications. And they actually just started reaching out to members before the plan even started to kind of sit down with them and just consult with them on their medications. And, you know, oh, it's okay. By doing that, you know, it gave these employees an additional resource on the RX side, and it also helped drive plan savings, which we'll see in a couple of slides. The third point was really we wanted coordinated care with Dr. Aiken and the other direct primary care providers, and so those communication lines were open between our teams. So, you know, as our pharmacists were looking through the claims, you know, they would reach out to Dr. Aiken and say, hey, this is an opportunity that we see, you know, we know this is a member in direct primary care. Can we talk about this employee? And Dr. Aiken and his team were great about, you know, saying yes and really offering coordinated care for these employees that really drove down plan costs. And finally, just expanded resources on the pharmacy side for employees. You know, a lot of people think that all pharmacies are the same, and they're really not. You know, independent pharmacies in your communities offer usually a wide set of services that a lot of the chain pharmacies don't offer. So, you know, free delivery, medication synchronization, different packaging options for different conditions or different circumstances for different people. Those are all things that we wanted to kind of build into the plan. And, you know, like I said, being in different communities as we all are on this call, you know, a lot of the independent pharmacies in your area probably offer similar services to this. So if you're interested in something like this, I would recommend trying to talk to an independent pharmacy in your area just to explore whether they offer things like this. So this slide goes over a little bit of the financial results for the plan. This was the cost per RX before we took over. It was at about $66. We got it down to around 52. That's pretty normal when you take out the kind of the middleman fees that Cristy mentioned with the spread pricing and aggregation of rebates and all of those things. You know, 15 to 20% is pretty normal. And so that decrease in cost at 21%, we were proud of that. But if you're able to kind of take out those gains that a lot of the pharmacy benefit managers play, you can achieve those savings.
Hey, Ed, I just want to say, you know, a lot of times when you, especially employers, if they don't know better, they would look at a $100 billion company like Optum and think to themselves, a big PBM has a lot more buying power and leverage in the acquisition of drugs. They can purchase drugs so much more inexpensively than a smaller PBM or much less an independent pharmacy. In this case, I think we showed that we beat them by just being transparent and doing the right thing. And, you know, hey, kudos to those of us who were really digging in and trying to figure this out for doing better than a $100 billion company could do.
Yeah, and just to add on to that, Cristy, that's a great point. And, you know, that comes up a lot, that question. and really the answer is yes, you know, the big PBMs negotiate better discounts than, you know, a lot of the independent players, but the employer groups aren't the beneficiaries of those discounts. And that's kind of where the spread pricing comes in. So that, you know, that deep discount isn't getting passed on to the employer group. That's kind of where the middle is making money on the deal. So when you get that out of there, you know, these savings can happen. So, you know, outside of just pricing, we really wanted that pharmacist engagement that we talked about a few slides ago. And this kind of patient result was one of the key opportunities that we had identified in the Optum claims file. And just to give you a little background on the situation, you know, we had identified in a PRESO, it's a brand name RX used to treat ulcerative colitis. And the plan was paying about $9,000 annually for it. It was about $766 a month. And so what we did is one of our Sona clinical pharmacists identified the opportunity and said, hey, you know, there could be an option to take a different medication here. You know, why don't we go ahead and dig into this a little bit further? They actually called the patient and had a phone conversation with them and learned that the member was actually pretty upset about the cost of the medication, and they were pretty nervous that they weren't going to be able to afford it for the long term. And so, you know, what happened is there's usually some pretty creative opportunities in RXs if you just look for them. And so what we were able to do is there's a compounding pharmacy here in Asheville that we were able to use and actually have that medication compounded. It was actually compounded to be a little bit more specifically for that person. And the cost savings of the compound were significant. It was $150 per RX total for the compounded medication versus that $766 a month. And so with those cost savings, we were actually able to provide the medication for free for the member, and the plan took that full $150 per RX and paid the full amount. And so, you know, it saved the plan $7,000 annually, but it also helped the member a lot. And, you know, the member called our pharmacist and just said, you know, thank you so much for finding this opportunity and for taking the time to just, you know, talk to me about my concerns with my drug spend. And so, you know, for everyone on the call, as you're kind of building plans similar to this, you know, finding an independent RX partner that's kind of willing to dive into the claims data can be pretty fruitful, both for the employer and the employee.
I'll just say, Evan, that when we were in the planning process, we identified around 10 employees that were in a similar situation. They were being prescribed a brand. There was the possibility that a therapeutic alternative that was generic was a reasonable thing to try. And so we opened up clinical time with and Tasha Michaels is pictured there in the little snapshot photo at the bottom. And so she was able to meet one-on-one with all 10 of those employees and create a similar, a similar pathway. Well, what happened on the plan side is that prior to the new plan year, they had two plans. They had a high deductible plan and a lower out-of-pocket PPO plan, but with a higher premium, right? It was like a buy-up plan. We identified that the only people that were on that buy-up plan were the ones that were taking expensive brand name drugs. So when we went through this process and helped those 10 employees understand that they have alternatives in the generic drug list that they could get for free and save the plan money, we were able to eliminate that copay plan. And the stop loss carrier that we have for this plan gave us a 2-point decrement. So we got a discount from stop loss because we streamlined the plan, and this was the key to being able to streamline that from 2 plans down to 1 plan. And so anyway, it had far-reaching effects, more than just what you're seeing on the screen.
So here's some of just the key takeaways. The first one's really just to get creative in the plan design and trying to engage local providers. You know, like Cristy said, it was a lot of upfront work to kind of design these plans in a way that incentivized members to, you know, utilize direct primary care or, you know, utilize an independent pharmacy. But it really did pay off. And, you know, I would encourage everyone to kind of look at those independent partners just that are willing to, you know, get creative with plan design and have a little bit more flexibility than maybe some of the bigger players in the market. The second point there, utilize expertise of clinical pharmacists. You know, we feel like pharmacies or pharmacists are really a resource that can help health plans. So finding a way to utilize their time to actually help the plan and help their members is worthwhile. Providing members with resources to be proactive. You know, direct primary care is a great example of that. You know, we're big believers in direct primary care. You know, giving people the tools to actually improve their health proactively is going to, you know, help the plan save, but also improve, you know, employee morale and all that good stuff. And finally, really just opening up the communication between providers. You know, Dr. Aiken and his team do a great job of reaching out to us if they have a complex patient where they just have a question on medications that they'd like input on. And we kind of do the same if, you know, we're talking to an employee over the phone and they bring up a condition that, you know, we think that their team doesn't know about, you know, we just go ahead and give them a call and fill them in on that. So if you can kind of build some open communication lines between the different providers in the plan, it goes a long way. Did I miss anything, Cristy?
I don't think so. Just in case anyone wants to Google this, this plan and the design and the fact that direct primary care played such an important role in pulling it off got recognized in the Journal of Managed Care and Specialty Pharmacy. If you want the link to it, I can email it to you, or you can Google it. It should take you there. It's a 2.5-page read. It won't take a smart person like all you guys 5 minutes to read it. But we were honored to be recognized in that way and be able to tell the story and how unique it was and innovative, and be recognized by you know, pharmacy folks from around the country. So I'm going to take us into the next part. The restaurant group case study sort of has 2 parts: the innovation in the pharmacy piece that was allowed because we had the foundation of direct primary care. But now, well, what happens when you need to go farther than that? When primary care and a good prescription drug plan can't handle the scope of what's needed. So this is where I'm going to just portray a story to you about an employee who needed ACL surgery, you know, hurt their knee, and we were able to explore a direct contract with a local orthopedic surgeon. And so here's that picture. So if direct primary care had not been the foundation of this plan, we could not have pulled this off. What you see in the screenshot there is a little picture of the Spruce Health app. And this is something that Dr. Aiken and Lantern Health uses to stay connected to their patients virtually. So this employee was compliant. And when we told them in the employee education meetings, as long as you start with direct primary care first, then you'll be able to make sure you pay the least amount of money for downstream care. Well, this employee heard that. And whether they use this Spruce Health app to reach out to Dr. Aiken virtually in the beginning, I can't actually remember. But the point is that employee started with Dr. Aiken first, and that was really the magic around this part of the case study, because if they hadn't done that, we believe we would have paid about 3 times more than we ended up paying for this particular surgery. So I'm calling this the love connection. My buddy Carl Schussler, who's also on the call, has a saying called the love triangle. And what he refers to by that is the direct primary care doctor, the local community pharmacist, and the local healthcare system. So I won't tread on his word, the love triangle. So we're just going to call this the love connection. We are all showing love to the plan and to the employer and the employees on the plan here. So this trifecta was very important in making sure that we were able to route this anterior cruciate ligament surgery in the right direction so that everyone could pay less money for it and get the highest quality. So the first member of the family, Dr. Aiken, and then here's myself, and then actually let me back up. When Dr. Aiken assessed this knee, he emailed me within the hour, I think, to say, I think we might have a surgery on our hands. And when I read that email, I reached out immediately to the third-party administrator, Aether Health. And here you can see Laura Hirsch and Lisa True, who we all got together and put our brain power into figuring this out. Within 48 hours, we had 2 great options, one of which was a local orthopedic surgeon. But we didn't just automatically go there. We did our due diligence. It's certainly preferable to keep an employee local so that they don't have to travel for a surgery, but that's just not where we opted first. We took a couple days to do our due diligence, and between the 4 of us, we really figured out what was the best place to go, but we always started with quality first. So at Dr. Aiken's suggestion, there was a bundle that included the facility fee and all the things that you see listed there. And that was something that Emerge Ortho in their Blue Ridge division hadn't done before. So when Dr. Boykin, who was the surgeon that we settled on at the right price, he really got in and helped coordinate that surgery to be done at a local freestanding independent surgery center. And that was probably the biggest piece of the pie, not paying a hospital facility fee to have this surgery done. The facility fee at the freestanding independent surgery center was much less. So that was a big key to that. So that's an important thing to remember. So I just wanted to use this slide to say thank you to Dr. Boykin for being an innovator himself. I said just a minute ago, this had not been done before in the Asheville area, from what we can tell, and hopefully it becomes the wave of the future, but hey, we have to have innovators to try new ideas first. So the term care coordination, is sometimes thrown around, but when you do it with the client in mind as your very first priority, and you start with quality first before you ever start talking about the price, that's the kind of care coordination where it actually works to everyone's good. And again, we hadn't done this before, but like if you've heard me say it once, you've probably heard me say it 1,000 times. All it takes is a good advisor and a little courage. So I think everyone on the team had the courage to dig in and try something new. And the restaurant group was really the benefactor of it. And of course, by default, the employee was too. And I'll just say this. This happened, I think, in January or February. No one knew what was lying ahead in the future of this restaurant group, right? Remember, in March, they have to shut down because of COVID. So not shelling out unnecessary and excessively inflated charges for an ACL surgery really set them up to better handle being shut down. And now that they're trying to open their doors back up and get back to their former glory, it's just a nice thing in retrospect that we were able to find the courage to try this new thing. So before I go through my advice here on this slide, I wonder if Dr. Aiken, if you would unmute and just give us a few of your thoughts.
Happy to, Cristy, thanks. So I think that this, perhaps for most people on this call is not a novel story. I think it's starting to happen more and more around the country in situations where the incentives are aligned. And for me, it represents a couple things. One, I think that in the direct primary care footprint, part of what I love about the model is that it really is it's a system in which doctors can treat everybody like they would somebody in their family. And so I think in a fee-for-service world, in my previous practices and other things, those incentives really weren't there. So just the nature of trying to get through my day really disallowed me to take more time and to investigate things to the degree that I would as if I was treating somebody in my own family. So really, my approach in this case with this patient really was just instinctive. It wasn't something that, was overall novel. It's just saying, hey, listen, this is somebody that I want to treat just like I would treat somebody in my own family. I know that they have to have surgery. I want them to go to the best, and I want that the value, kind of the cost to them at the end of the day, to be the lowest. And how can we, given the parameters that exist in their plan, make that happen? And so then having the time to actually try to coordinate that and make it happen. So certainly a great deal of credit goes to Dr. Boykin and the team at Emerge Ortho. They're, I think, a strong independent player in our state and in our community and want to do right by patients. And so we're really willing to think forward on this. And that was an essential element in the plan or in making this work. And then the second is that I think, for certainly for the folks thinking about this from an entrepreneurial or kind of how do we replicate this more broadly on the call, I would say that, where this could potentially go moving forward is thinking about basically developing the tools to support this to happen really almost at the point of care. So if there's a way, right now for me, if this comes up for any of our patients, we're doing some work on the back end and trying to navigate and leaning on partners like Cristy and Aether and other folks to make this happen. I'm reaching out directly to Dr. Boykin in this case, having a conversation with him on the phone, explaining the situation in terms of trying to facilitate this. But if this ultimately becomes more and more of a norm, is there some type of a place that we can all go to almost at the point of care and say, hey, yeah, here are the options. These are vetted, and kind of have the technology to support that. So I know several folks that have commented and kind of on the call are trying to think about how we do that. And I think it's really, really exciting. And at the end of the day is really totally focused in on the patient first and foremost. But when we do that, ultimately at the end of the day, everybody wins because the cost is less and the quality is higher.
Agreed. In the interest of time, because we only have 10 minutes left, I'm just going to skip all the way down to the lesson learned for us. And that is, we wish we would have thought of the physical therapy piece ahead of time, because those claims did come in processed through the PPO network. And I know we could have gotten a better price on a cash basis. So out of all those bullet points, I'm sure you've already read them to yourself, but that was the lesson learned. Next time, I'm sure we're going to try to incorporate the physical therapy after a surgery like this in the cash bundle. So I'm going to move on. So in conclusion, I have a couple of parting thoughts for you. I don't know if you follow this guy, but if you don't, you should. Dr. Eric Bricker had an amazing video yesterday. He has a daily video library that can be delivered to your inbox. It's called A Healthcare Z. And yesterday's video was called The Decline of Employer Family Coverage, but essentially he tracked how we're actually going backwards, not forwards, as a society, and attributed it to the increasing cost of healthcare. So if you watch that video, you will see he's a follow the numbers kind of guy, but he's also a doctor, an internal medicine doctor. And he essentially showed that over the last 10 years, families are actually going backwards in terms of their family income, while healthcare is costing more. And so if you don't follow him, you really should. Go ahead and take my advice and get subscribed to his video library. So, you know, here's what we're trying to solve for. Let's solve for the care instead of having a third party tell us what we can and cannot do in the doctor's office. And instead of reinventing the wheel, we just really need to build something new that makes the old model obsolete. This is the Buckminster Fuller quote. And, you know, a lot of people will ask me, well, can we just fix this or tinker with that? Sometimes you can, but I think as a model, switching over to direct primary care and building something around that makes the old model obsolete. So speaking of building, let's pretend that we're like building a house, like a custom employer-built health plan, instead of an insurer-built health plan. That foundation is always direct primary care, and then all the rest of the strategies, brick by brick, can be built until you are ready as an employer to say, I think we've got all of our bases covered and we're ready to put a roof on this house and invite employees in the front door. So it absolutely can be done. And this is something that good advisors with employers who have a little courage do every day. So I just want to say thank you again. I want to ask you that if you're not a member of the Free Market Medical Association, joining is very easy. Just go to fmma.org and click join. If you're not a resident of North or South Carolina, where you would be in this chapter, click on the members/chapters tab and reach out to the chapter leader in your state. Membership is $325 a year. It's the best deal in town. And like I alluded to earlier, the Shop Health app is a marketplace where you can look for and access cash-based procedures at independent surgery centers and other healthcare, you know, services that you might need without having to go through a middleman to get it. Okay, I'm going to try something new I've never done before. I'm not sure if I can do it. Oh man, I've never done a poll before, and I'm wondering if I have the ability to do it while my screen, or while the PowerPoint is up. I apologize. I told you earlier, I'm not a Zoom expert. Let's see. Okay, we're going to skip that part, and I'll just tell you what the questions were. And if you want to email me those questions or answers to those questions as they pertain to you, please do that, because I'd like to know your opinion. First of all, I would love to know how frequently you'd like to have these meetings, monthly, quarterly, twice a year, once a year. As your Carolina's chapter leader, I've been terrible, and this is the first meeting that we have had in a year. So I apologize for that. But if you'd like to meet more frequently and explore more topics on the free market medicine topic list, I would first of all just like to know how often you'd like to meet. And then the second question is, what topic would you like to explore later? Maybe with the next meeting? Would it be certificate of need laws? Would it be more employer case studies? Would it be maybe a direct primary care panel that you can ask any question under the sun to, you know, just give me some ideas about what the subject matter might be. And I'm drawing a blank on the third question, so I apologize. Someday I'll learn how to take a poll on Zoom. So let's stay in touch with Dr. Purcell. Thank you, Dr. Purcell, for joining us first. Dr. Aiken of Lantern Health, Evan Bruder of Sona Pharmacy in Asheville, and Sona Benefits, which if this didn't already come across in the presentation, is a bona fide, fully capable nationwide pharmacy benefits manager. And you can talk to Evan about how using Sona Benefits as your pharmacy benefit manager might help support you. And then lastly, me, I'm the president of Custom Benefit Solutions and your chapter leader for now until someone else takes the reins from me. So with that, I'm going to just end the slideshow and try to get back to my Zoom controls so I can check the chat and the Q&A. Okay. So, and just in case, in the next 3 minutes, I know we're not going to get to all these questions, but I will log all of them into some emails and direct them to which panelists that should really answer them and connect you guys via email. So here's a question for Dr. Aiken or Dr. Purcell, asking what are the best electronic medical records to use that patients can track on their smartphones?
I'll jump in just real quick. I don't know if that's a DPC doctor or a physician who's asking that question or not, but there are several EMR systems that are DPC friendly, I would say, that that have systems. We use a system called Atlas, which everything is integrated: the texting, the emailing, the EMR portion, the drug dispensary portion. All that stuff's integrated into the system. But there are other. You mentioned Spruce earlier. There are other applications and that work with EMR systems. So there's several different options out there, and it's just a matter of which one you like the best. So there's not like one go-to source, I would say. But if you're a physician considering DPC, I would look at chat it up with other DPC doctors to see which one they like, and then most of them you can test them out, and so you can try them and figure out which one seems to work best for you.
Excellent.
Yeah, nothing significant to add there. I think increasingly almost any EMR has some kind of a mobile app with it, if you're more on the consumer lens side. And a lot of EMRs are now starting to communicate in with more native applications like Apple's Health, or, so that basically consumers and patients can feel more empowered to have their own data. And yeah, agree with Shane completely. The two kind of principal platforms I see most people in DPC using are either Atlas or Elation plus Spruce. That's the combo that we're on.
Thanks for all the kudos on the Q&A and the chat. I really appreciate everyone giving me grace for this first try, having a virtual meeting. I hope that we are not that far off. I hope we're at least less than 12 months away from being able to get back together in person again. But until we get to that place, we'll keep up with each other via screens. I think everything else in the Q&A and in the chat can be answered offline. So I'll work on that today. I'll also convert this recording to video and get it distributed to everyone who registered for the webinar. And I just want to say thanks again and have an excellent remainder to your Friday and a great weekend to everyone. Thanks again for joining us.